Well, hello and welcome to the Community Matters Understanding Social Determinants of Health to Reduce Dementia Risk webinar series. Thank you all again for joining us today and being here. My name is Michael Lewis, and I'm an Associate Director with the Bold Public Health Center of Excellence on Dementia Risk Reduction at the Alzheimer's Association. Before we get into our presentations today, I do want to highlight this wonderful opportunity for local health departments. We do have our Healthy Brain Initiative Roadmap Strategist application that does close tomorrow. So this opportunity is a cohort of leaders just focusing on brain health within their health department as well as their community. And this is a wonderful opportunity to receive direct funding, technical assistance, as well as peer support. So please be sure to take a look at the application. If you feel like you qualify, please submit that application by end of day tomorrow. But what you're here for, of course, is the Social Determinants of Health webinar series. And then over the summer, we've discussed economic stability, nutrition, social isolation, and engagement. However, today we're really going to focus on those healthy environments and hear from our academic speaker as well as our health department speaker on how this work can happen in practice. So today, we'll be focusing on creating healthier environments, harnessing social determinants for dementia risk reduction. And this is our fourth webinar, but not our final, of this Social Determinants of Health webinar summer series. And we want to say thank you to over 5,000 registrants for this entire series. But specifically for today, we reached our mark at 15,000 or 1,500, let me correct that, registrants for today's sessions. So we are thrilled to have you all from diverse backgrounds here. So please just let us know where you're joining us from, as well as what's the first thing that comes to your mind when you hear healthy environment. So I'll go first and kind of kick us off. I am in Katy, Texas. And when I first think about healthier environment, the first thing that comes to my mind is clean water. So I will come back to the chat and take a look as I go over the housekeeping items. Keep letting us know where you're from, as well as what's the first thing that comes to your mind. So again, before we get started, this webinar is hosted by the Alzheimer's Association Public Health Center of Excellence on Dementia Risk Reduction, and it is funded through a cooperative agreement with the CDC. And then as a reminder, this webinar is recorded and will be shared with all registrants. So any personal use of recording this webinar or use of AI recording is not allowed, and we will have to remove those platforms from this webinar. And then lastly, if you would like, you can use closed captioning, and you can enable that by using the toolbox at the bottom of your screen. As well as please feel free to put any questions that you have for our speakers today in the Q&A box, or someone from our public health team or one of the speakers will be able to respond, or we'll just hold it for our Q&A session towards the end. So brief overview of the agenda. We'll go over the learning objectives, hear from our presenters, and then go into the Q&A session. So those learning objectives for today is we'll hear from our academic expert on examining how environmental factors and social determinants of health contribute to dementia risk reduction, as well as hear from our health department speaker about the strategies that are being integrated in the community as well as the health department to reduce dementia risk. So today we'll hear from Dr. Ganesh Babulal, who is an Associate Professor of Neurology at Washington University School of Medicine. And then we'll hear from Naina Sasi, who is the Director of Policy and Planning with the Michigan Department of Health and Human Services. So without any further ado, I'm going to turn it over to Dr. Ganesh, and we're going to hear from him on his presentation.
All right, thank you so much for that introduction. Let me go ahead and share my screen. And can you see the screen in presenter mode or presentation mode?
Correct.
All right, thank you so much for confirming. So good morning, good afternoon. I assume we might have a few time zones here, so I want to be inclusive of everyone. It's a pleasure to join you here to speak about an area of my research that's near and dear to my heart, but also I think critical and important when we're thinking about not just research itself, but also how we're aging in environments that may be beneficial for our health, but also may be adversive to our health. So I'll first start off with just defining very broadly a little bit about structural and social determinants of health. So roughly about 20% of an individual's health is actually tied to clinical care, which includes access to care, quality of care, and those health services obtained. The remaining 80% of an individual's health is really tied to their physical environment and the socioeconomic factors like income, community, education, but also behavioral factors like diet, exercising, or smoking. And as you can see, 80% is really broken down as follows. Roughly 40% is attributed to socioeconomic factors, 10% to the physical environment, and 30% to health behavior. And to put this into perspective, what you're seeing at 20% is really just the tip of the iceberg in terms of when it comes to everything that might impact the individual as they present either to a clinic or to a hospital. So this is a variation to other structural and social determinants of health, the framework from the Kaiser Family Foundation. All of the dimensions from economic stability to healthcare systems are present. But for the sake of time, I won't really go into the dimensions for the subcomponents, but I really just want to broadly define that so that we can delimit the space a little bit to understand what are all these factors that typically impact health. So the numbers that I'll quote you are from 2018, but I'm fairly certain they likely have just increased since then, roughly over the past 6 years. Annually here in the United States, roughly 1.5 million individuals will experience homelessness. 3.6 million people cannot access medical care due to a lack of transportation. 40 million face hunger on a daily basis, and roughly about 12% of households are food insecure. If you're homeless, for example, living in unsafe or unhealthy conditions, you don't have transportation to get to medical appointments or to access food, obviously that's going to impact your ability not just to age in place, but also your health. But what we also know is that children experiencing food insecurity may be at more 2 to 4 times more of health problems compared to children from low income households or who are not food secure. The same thing translates to adults. And the whole reason for discussing this is that these poor health outcomes really contribute to an increased risk of not just readmission to healthcare settings, but they also increase medical costs and care risks and may put individuals at risk for ADRD or Alzheimer's disease and related dementia. So where you live can actually determine not just how well, but more importantly, how long you live. And this heat map is showing right now the range in life expectancy among countries in the United States, ranging from age 66 to about age 87. And in some case, the difference really, depending on where you live, can exceed roughly about 20 years. So, for example, life expectancy is significantly lower in the southern states compared to the northern states. And what I'm sure some of you might recognize the two demarcated curves here is this is what's more commonly known as the stroke belt. More recently, this is also known as the diabetes belt because stroke and diabetes are very closely intertwined and related to each other. And then as of, I want to say 2 years ago, the Alzheimer's Association came out with a heat map of looking at cases distributed across the United States as it relates to Alzheimer's disease. And as you can see, overlapped on top of each other, there's a significant band within that same region where you can see a higher proportion of cases are present within that belt, which is also known as the Deep South disparities. So many of you may or may not recognize this figure to the right. This was recently updated roughly about 2 months ago. These are the modifiable risk factors as identified by the Lancet Commission on Dementia Care and Prevention. There are some new additions to this year, including high LDL cholesterol and vision loss or visual loss. And what I want to point out very briefly, if you've never seen this before, are two interesting themes. The first is the bulk of the risk factors really center in midlife when we're thinking about aging as a spectrum that likely contribute to that higher risk of Alzheimer's disease and related dementia. But more importantly, air pollution is really the only risk factor that is proximally related to the environment. But what I would like to contend, or at least posit, is that all of these additional risk factors are actually directly or indirectly modified by the environment. So this graph shows infant mortality here in the United States for the years 2020 and 2021, and it's broken down by race and ethnicity of the mother. It compares the number of deaths per 1,000 live births for various ethno-racial groups. And essentially what it seems to codify is that mothers who are racialized as non-Hispanic Black have the highest infant mortality with a slight increase from 2020 to 2021. And with the exception of non-Hispanic Asians, those racialized, all other ethno-racial groups actually had higher mortality compared to non-Hispanic whites. These two graphs really depict disparities in wealth distribution here in the United States and the median household wealth based on race, ethnicity, and education. On the figure to the left, what you'll see is a significant proportion of individuals racialized as Black or Hispanic. Those families typically have lower wealth, roughly about 0 to 25,000 compared to white families. But in comparison, there's a larger proportion of wealthier families who are whites, especially when we're looking at the 500,000 to roughly about the 1 million. And really what this shows is there's an intergenerational inheritance of wealth. And what I will also argue, there's also an intergenerational inheritance of health. The figure to the right depicts white households that have the highest median income at virtually every education level, with significantly higher wealth for those with a bachelor's degree or higher. And what you'll note is this Black or Hispanic household typically have a notably lower median wealth increase across education levels, even among those with a postgraduate degree. White household tends to have more wealth compared to Black and Hispanic household, even at the same education level. And so the reason why I cite these larger numbers is to provide some context, again, to sort of set the stage when we're thinking about structural and social determinants of health, primarily because these factors not just impact brain health as we're aging from, in utero all the way into the 8th, 9th, 10th decade of life. But more importantly, it can also determine the trajectory and the risk of Alzheimer's disease and related dementia. And what I'd like to do is briefly start really at birth. So I'm going to transition. I'll talk about a few studies that illustrate the impact of these determinants really across the lifespan, but also beginning in utero. So this study was conducted here at Washington University School of Medicine in the NICU and the PICU at their local children's hospital. This study involved roughly 319 mother and infant dyads or pairs. And it was a maternal child health study looking at overall outcome, but more importantly, what this particular study examined was neighborhood crime and how much that crime impacted the brain function of newborns. And so they used the mother's home address and they examined crime data, and this included both property crime and violent crime. And that was mapped relative to the national average in the St. Louis metropolitan area and the surrounding areas. And the two key findings from this study was that they found neighborhood crime and maternal stress were significant factors where disadvantaged mothers in areas with higher crime levels and property and violent crime were linked to much higher psychosocial stress during pregnancy. And the resulting impact on the neonates showed that high property crime during pregnancy was associated with weaker functional connectivity, that is, the brain regions communicating to each other, and specifically between the thalamus and the default mode network in neonates. And there was also an impact on violent crime between the thalamus and the amygdala and the hippocampus. Again, the amygdala is a fear processing center. The hippocampus is roughly the seat of memory, allows us to remember things, both short and long-term memory. So continuing in that same vein, this study, again, came from the same cohort, and it had about 280 mother and infant dyads. And so what they also found was that maternal social disadvantage, this was measured by income and education, was linked to reduced cortical and subcortical gray matter, white matter, and cortical folding within newborns. These are all very critical components in terms of the brain's hardware to be able to start learning and developing, building not just cognitive function, but emotional resilience, social resilience. They also found that psychosocial stress showed no relationship to cortical measures, but prenatal exposure to maternal social disadvantage really impact not just brain development, but it could also potentially impact the ability to learn within the first 5 years of life. I think I've got one more study to illustrate this point, but taking it a little bit further. So this was a cross-sectional study that analyzed data from 2019 to 2021 using the National Health Interview Survey. And it focused on roughly 16,000 children across the United States. And out of that 16,000, roughly about 5% had been exposed to neighborhood violence. And what they found in their adjusted analysis was that violence exposure led to higher rates of delayed or foregone mental health care. It reduced access to prescription medications. It also led to an increase in terms of difficulty for that household to pay their medical bills. And there were also a lot more frequent trips to urgent care and emergency services. And so what these results really, I think, epitomize is that not just violence prevention program can work on improving child health, but there's also this cascading effect to the larger family. Now, more recently, we undertook a study here in St. Louis where we wanted to look at the relationship between the brain age gap and where a person resided within the city. And the brain age gap is a quantified metric where you can look at the discrepancies between the brain's chronological age and the person's biological age. And it really provides a measure of brain health. And so essentially, if there's a discrepancy between the biological brain's age and then their actual chronological age, you can say that the brain age gap is wide or wider or non-existent. And essentially what we found was areas that had the highest level of deprivation in St. Louis, and typically this was within the northern and southeastern portions of the city, the individuals that resided within those areas also were found to have a higher brain age gap as quantified using an MRI. So up until now, I've been addressing some of the existing health disparities when we're thinking just about where a person lives in terms of their location. So at the surface level, what we do know is that your neighborhood's location has an impact on cognitive function. So for example, those that live in neighborhoods with medium to high density, so medium population to higher density populations, they actually tend to perform much better on tasks that assess overall cognitive function, memory, and specifically executive function. Conversely, those that resided in rural communities with a much smaller population density, they actually had lower scores on verbal and attention tasks, orientation tasks. And what they found was half the difference in terms of this cognitive function outcome was explained by the lower levels of education, particularly among older respondents residing in rural areas. And the other half was really due to chronic stress, lack of insurance, and overall lower household income. We also know that those residing in neighborhoods that have high resources, for example, like recreational parks, walking paths, health food stores that are stocked with leafy green vegetables, things that are replenished fresh on a daily basis, they also tend to have a higher overall cognitive function. But interestingly enough, this relationship was only found for those that are racialized as non-Hispanic whites. The effect size was much smaller for those racialized as Black or African American, which again emphasizes the importance of not just access and policies, but also other potential systems that might be impacting access. So I think I might have 7 more minutes left. I want to pivot, go up a little higher now to the macro system and tie back into the Lancet Commission looking at air pollution. There's been a lot of publications coming about this. And so worldwide, roughly about 2.6 billion people use heating and cooking sources that are very polluting, which includes bio-waste from animals, kerosene or coal. And of the roughly 4 million annual deaths from pollution, the majority are due to pulmonary cerebrovascular pathologies. What's interesting enough, though, is that children and women tend to be the primary collector of these types of fuel sources, and they're also exposed at a much higher rate and are typically the ones that are the resulting casualties. But here in the United States, the average actually American spends roughly about 90% of their life within a building, whether that's work or home or, someplace out in the community. What we do know is air quality is 2 to 5 times worse in some of these areas. And one of the reasons why, compared to outside, one of the reasons why is within the home, things like carpet, combustion from cooking, like water, the stove, heating, if you're smoking indoors, but also outdoor pollutants that get trapped inside the home increase that risk and that toxicity because you're breathing it in all the time. The use of certain cleaning products and beauty products and also radon increase this risk of air pollution. Now, typically, this usually will result in respiratory illnesses like asthma, allergies, COPD, or lung cancer. But I want to talk about the outside for a little bit. So this study was published a few years ago, and they assessed roughly about 5,400 different sources using the EPA's national emission inventory across the entire United States, the contiguous United States. And they examined roughly about 50,000 grid cells. And what they found was in the figure to the right-hand side, compared to non-Hispanic whites, communities of color, as denoted by POC's person of color, Black, Hispanic, or Asian, were disproportionately exposed to more pollution, as denoted by the red and across these multiple different sources here, compared to their white counterparts. And we also found that those communities tend to reside near heavy industry, utility companies, construction, and highways, which are all polluting sources. And in the figure to the right, they ran the same analysis to see whether or not there were differences between those that resided in urban areas versus rural areas. And they didn't really see a significant difference in terms of one group being at a lower risk compared to the other. So here's what makes that last slide a little bit more powerful. So over the past 10 years, there's been a lot of evidence, specifically systematic reviews and meta-analyses that are coming out to look at the really robust association between air pollution and also cognitive decline. And what some of the studies have found is that there sure enough is a relationship where specifically particulate matter 2.5 has been identified to increase the risk of cognitive impairment and subsequent dementia, irrespective of the etiology. And some of the thoughts about this is that the mechanism that's really driving this change is that inhalation of these gases and particles really pulls in the matter within the brain, but it crosses the blood-brain barrier. And what it does is catalyzes a neuroinflammatory response within the brain, followed by microglial activation, which increases the production of reactive oxygen species, leading to things like neuronal degeneration or amyloid deposits that are heavily implicated in Alzheimer's disease. And there's just a new study that I read yesterday that talked about light pollution being also associated with cognitive decline because of that disruption in terms of sleep and the circadian rhythm. And so the poor quality sleep you have has been shown to be associated with a higher risk of beta amyloid accumulation, and also tau accumulation, leading to Alzheimer's disease. So I've got 2 more slides to really quickly touch on. Homelessness, I'll tie right back to this because I think this is one of those unfortunately uncovered and not really well discussed issue here right now in terms of not just medicine in general, but also in terms of our social systems and policy. Homelessness is a chronic systemic and societal issue that affects roughly about 500,000 adults and children on any given night in the United States. And on average, persons who experience homelessness have a life expectancy of 50 years, which is compared to the average life expectancy in the United States, that's about 70 years for an individual who resides in a home. And based on the 2023 annual homeless assessment report to Congress, roughly about 50% of those who are homeless or unhoused are non-white. So the number of individuals experiencing homelessness, unfortunately, has been increasing over time and has increased roughly about 12% based on the point in time count. And this is really the highest number of individuals reported experiencing homelessness on a single night since they started counting in 2017. What they also found was that individuals who self-identify as Black made up roughly about 13%, who make up 32% of the US population, represent roughly about 21% of the US population living in poverty, but more importantly, comprise roughly about 37% of those that are experiencing homelessness. There's this also noted increase, roughly about 40% in the number of people experiencing homelessness who identify as Asian or Asian American. So we're starting to see this trend in terms of racial and ethnic disparity expanding. And roughly about 7 in 10 individuals experiencing homelessness actually resided in homes without children present. Nearly 3 in every 10 individuals experiencing homelessness did so if they actually had a family and children with them. So it's not typically just an individual that's being impacted, but largely their partners or family members that are with them. So we conducted a study roughly a few years ago that was published and freely available to really look at the relationship between homelessness and dementia. And out of all of the studies that we found, only about 9 met inclusion criteria for us to examine. And 6 out of that 9 cohort actually centered on the veteran population because you can track them a little bit easier due to the VA system. And what we did find out and we did note was that homelessness is a significant risk for dementia. It's also a consequence of dementia, but it can also co-vary with other comorbidities. And I'll talk a little bit about that last point there, because what we do know is if you're typically homeless and you're at risk for dementia, there are other chronic comorbid conditions that might be impacting that risk, like traumatic brain injury, economic and socioeconomic deprivation, malnutrition, mood disorders like depression, schizophrenia, bipolar disorder, anxiety, and also substance abuse. And so it's unfortunately not a clear cut when we're thinking about the risk when we're focusing on Alzheimer's disease and related dementia. What we also noted is that law enforcement officers are typically the first responders in the front line dealing with these very complex situations. And oftentimes resulting in an adverse outcome, especially for minoritized individuals. But now, thankfully, there has been a concerted focus in terms of street medicine organizations delivering essential primary care and housing resources to houseless patients and individuals residing in urban areas. So one example is that is Doctors Without Walls, which is a volunteer-run Santa Barbara-based organization that delivers healthcare to hundreds of homeless patients within their area. And here in St. Louis, we have a similar organization called the Urban League that works within the space, and they've been incredible in working to address these complex systems. So I know a lot of this talk and this conversation has been a bit negative in terms of looking at those risk factors, but I think it's very critical for us to understand what are those pain points within the system to understand how can we start to develop equitable solutions to address this on a not just equitable level, but also nationally throughout the United States. So that's all for me. I will stop sharing and turn it over to my other colleague. Thank you.
Thank you, Dr. Babulal. We appreciate your presentation today, and you have some wonderful questions in the Q&A box that we look forward to answering during the Q&A session. So please be sure to enter any questions that you have for Dr. Babulal in that Q&A box, and we'll get to it right after we hear from Nina with the Michigan Department of Health and Human Services.
Sorry about that. I'm struggling with technology today, but good afternoon. As mentioned, I'm Nina Sassy, and I'm the Policy and Planning Director with the Michigan Department of Health and Human Services. And I'm excited to talk about our SDOH strategy. I think it's time to talk about some solutions and what we've been doing at the state level. So I'm not going to spend a lot of time on this slide. I think that Dr. Ganesh did such a wonderful job of really breaking down what social determinants of health is. And there's so many things that go into the social and environmental structure that really influence health outcomes. The takeaway here is just to remember that SDOH, or social determinants of health, really account for 80% of health outcomes. So what happens in a clinician session is about 20, and what happens outside of that is about 80. So it's really important that we prioritize all of these physical and social and environmental factors that really truly drive health outcomes. And before we do that, I think it's important to also acknowledge that there are a number of historic policies and systems in place that really exacerbate and continue health disparities. And so acknowledging that, especially as we go through data and we show repeatedly, that we have higher disparities in one population versus another, it's so important that we really level set on why. There's a number of policies like redlining that contributed to factories being able to move in areas that were densely populated by minority populations. There's zoning, there's racial segregation, there's so many historical policies that have influenced that and that continue to be intertwined in the social construct of our country. So acknowledging that as a first step as we think about solutions is really critical. So let's talk about our statewide social determinants of health strategy. As we were thinking about what we can do as a state government entity, it's important to make sure that we were taking this in bite sizes. And so with phase one, we released that in April of 2022. And as you can imagine, there was a lot that we wanted to make sure that we included in this with also being ensured that we were able to take a deep dive. And so we started with just thinking about all of those different investments as it results to COVID, thinking about how we were able to mobilize resources, what were some of those lessons learned. And at the same time, we had a number of wonderful statewide reports that were released during that time. We had our Racial Disparities Task Force report, we had a Poverty Task Force report, we had our first statewide housing plan, we had a food insecurity report. We had such wealth of knowledge and recommendations. And now it was time to really think about how do we build upon those recommendations and really move towards interventions that can really help move the needle. So in phase one, we focused on food security, housing stability, and health equity. And that was our attempt to really kind of narrow the scope. As mentioned, social determinants of health is made up of so many different factors, and we continue to have programs throughout our department that allow us to address all of those domains. But we wanted to be more intentional about our work. And so to be able to take a deeper dive and think about how we're better aligning our work across the department and with other state agencies, thinking about how we're improving service delivery, think about space in terms of innovation as we identify gaps. And so we started with food security, housing stability, and health equity, as I mentioned, and really began to think about who's most impacted. So where are those health disparities? What resources do we already have out there? And how can we make sure that we're continuing to improve the programs that we currently have? So it was really that refinement stage of looking at our existing infrastructure and really bringing together those state and local partners to have that introspective look. And phase two, which was launched in January of 2023, we looked at it in terms of a holistic approach. We got a lot of great feedback in phase one and thinking about how can we use technology in a way that really connects people to resources? And so we prioritize community information exchange. And essentially that's about how we make sure that systems are interoperable. How is information being connected? So as people are looking for connections to resources in terms of clinical care and social care, how are we getting that information so that we can make the best informed decision as a clinician, as a social care worker at the state level as we allocate resources and so forth? We also know that there's gaps as it relates to technology, and we wanted to make sure that we complemented that with a human element. So as we think about community health workers, navigators, they go by so many different titles, but they're really those trusted folks in community that help people navigate the system and get the resources that they want. We wanted to prioritize that in phase two. And so what we did is we convened two statewide bodies. We released a nomination period where we have folks apply to be seated on these different committees. And then we worked with them to ensure that we had diverse perspectives at the table. And we can really think about what are some of the recommendations as we think about a statewide community information exchange. What are some of the recommendations that we need as we think about CHW sustainability? And then we also worked on our SDOH accelerator plan to prevent chronic disease. And I'm going to talk about that a little bit more in the next few slides. Now, in phase three, which we just launched this January, we began to continue to build on phase one and phase two. And now we're in that space of innovation where we're thinking about where are the gaps. And as we think about gaps, we know that it's important that there's never going to be a one-size-fits-all solution. All of our work should really truly be community-led. And so with these SDOH hubs, these are really our attempt at the state to develop a framework that would allow us to better support our local leaders through these SDOH hubs to really improve service care delivery and provide technical support. We're also looking at how do we really address the root cause as it relates to social determinants of health. And one approach is health in all policies. So thinking about how do we improve transportation? How do we look at it with the lens of equity and how that relates to health outcomes and so forth. And then again, we want to be so intentional about how we're closing the disparity gap and what very specific interventions we're doing to do that. So I mentioned that within phase 2, we released the SDOH Accelerator Plan, and I'm going to talk to you about how that came about and how we ensured that we had a lot of different perspectives at the table. And again, what are some of the next steps and how you can be involved in those next steps. So we received a federal grant through the CDC, and we were able to braid that together with some of our state funding as we thought about putting together this accelerator plan. We wanted to make sure that we had flexible funding that would allow us to incentivize community resident participation, and that we were also being inclusive of the number of regions and communities throughout our department, throughout our state. And so with the accelerator plan, we took the approach of ensuring that in the forefront, we had community engagement, and that was done through regional listening sessions, and I'll talk about those. We also assembled a leadership team. So again, this is a statewide body where we had a nomination period, and we had about 18 folks that participated there, and they really helped guide the framework for the regional listening sessions, as well as the development of the accelerator plan. And then we worked with public sector consultants to really look at what we were doing within the department in terms of chronic disease prevention and treatment, and what are some of the promising practices that are occurring at the national level. So I mentioned the community engagement piece, and this is so critical because what we learned in community really drives, and it should continue to drive the work that we do. There's never going to be a one-size-fits-all approach. There's so much diversity here in Michigan in terms of needs of community and assets. And so we wanted to make sure that we had a framework that allowed us to really capture the assets in community while also hearing what are the gaps that we can improve at the state level. And so these were facilitated and hosted by our locals. We provided grants to them so that they can administer these. And we also had the University of Michigan support facilitation. So it was really about going out in community, hosting these sessions, and hearing firsthand what are some of the barriers as it relates to those social and environmental factors. And then with the leadership team, we actually had 23 members, so a little more than I originally stated, but they had a makeup of all of these different groups and thinking about, as we really want to focus on the intersection of social determinants of health and chronic conditions, like how does all of our work come together? And they really help guide the development of the accelerator plan, and like I mentioned before, the structure for those regional listening sessions. The promising practices, there was a lot learned there. We are a massive department, and there were some areas of redundancy and some gaps. And so it was great to have that look from a third party to really help us think about what we can do internally in terms of our program delivery. So now I'm going to talk about some of the key insights and findings that we got through the regional listening sessions, as well as that internal review by the public sector consultants. And so this is just an overview of where we held our regional listening sessions. You'll see that we had coverage in 9 of the 10 prosperity regions. One of the regions received this CDC grant themselves, and so they didn't actively participate in these sessions. They hosted their own and had their own approach. But we did get a lot of information across the state, and it was just such a wealth of information. And there's a more detailed report that I can definitely share afterwards, where it really synthesized some of the key themes and some of the differences and variants from community to community. But what I want to highlight here are some of the key takeaways. And as you can imagine, as you think about food security, maybe in the UP versus maybe a metropolitan area, food security is going to look a little bit different. But in all, what we found is that there was definitely a highlight of grocery stores are hard to reach. So again, it's that intersection of as we think about food and transportation and mobility. And it made us think about what are some of the programs that we're doing to really address that gap. We recently received an appropriation for the food delivery program, which is allowing us to look at this more closely in Kent County and Wayne County. So I'm excited to see the findings of that in the next few years. We also looked at transportation and healthcare. So again, looking at where there's areas and opportunities based on what we heard in those regional listening sessions. It was so just so much great information, and it made us think. Like we went in with expectations of wondering like what would really strike community in terms of what they would want us to prioritize. And what we heard were things that we were already prioritizing as a department. So it was great to hear that. It was also great to hear how we can improve the programs that are existing. Right here, we really got some great feedback about built environment. And as we think about investments in infrastructure, thinking beyond just driving and thinking about walkability, mobility in a different way. And then housing. Housing continues to be a priority across the state as rates continue to go up in terms of renting and mortgage rates. There's not enough affordable housing. So as we think about from community to community, that was definitely a common theme. Now, what were some of the barriers that were identified through the public sector consultant analysis? Those are highlighted here. So sometimes within our programs, they're really driven by where the funding source is coming from. So as you can imagine, if we receive a federal grant, that really drives how we can spend the funds the same way as if it's state funded and there's legislative requirements. And so having that narrow focus really limits how we can really address the needs of each community. And so that was definitely a barrier that was identified during this findings. Lack of collaboration. And that's something that we continue to improve upon within the department of thinking about how our work comes together, making sure that at the end of this, the community resident has no wrong door and that they can really benefit from all of the resources available. The complexity of egrams as we think about who are the partners that we're bringing to the table to really help drive these interventions. We're working through those in a number of pilots as well. Opportunities. So on a positive note, we looked at what are some of the things that we can do right now within our department. And one that I'd like to highlight is that we worked with the Executive Office of the Governor and we established what we're calling an SDOH interagency work group. And what that is a collection of all of our state agency partners. So we have our Housing Development Authority partners at the table. We have our Michigan Economic Development Commission at the table. We have all of these different partners that may not see how their work influences health, but it does. And we're thinking about how we infuse equity in all of that work and how that translates to positive health outcomes. So I'm excited about that, excited about all of the things that we have listed here. I know I have a limited amount of time, so I really want to focus on what you can do in your work as you think about, the intersection of SDOH and dementia in particular. And so both I and Dr. Ganesh talked about really social determinants of health and all of those factors that influence health outcomes. So as you're thinking about treatment plans, as folks are leaving that clinical setting, it's really important to think about what environment they may be going into. Not only how you can support getting the resources that they need, but making sure that their treatment plan aligns with what they actually have available to them. So here are some tips here in terms of what we were able to capture through our regional listening sessions, through our programs, and as we think about how we can better support the complete care of an individual as it relates to this intersection here. Through our social determinants of health hubs, and I mentioned that in the earlier slide, these are really locally led hubs or collections or networks of partners that are both clinical and social care partners. And what they do is they work together and they share information so that they can provide that comprehensive care to individuals. And so with our hubs, we have this ecosystem of thinking about who are all the different entities that need to be at the table to really have that comprehensive care. And so we have 16 hubs across the state right now. This map really kind of shows the breakdown. We released cohort 1 in January of this year, and you can see the makeup here. we were slowly rolling these out because, as you can imagine, each community is at a different place. You know, there's existing collaboratives within each community, and we wanted to make sure that we weren't replacing that. Like, there's beauty in having those networks and partners that are doing work in this space, and they're built in relationships. And so we wanted to make sure that we were coming in and being supportive of that, and then thinking who else can be complementary as it relates to bringing them to the table. And so we released, as I mentioned, cohort 1 in January, and then in April, we released cohort 2, and in May, cohort 3. And what we have listed here are what are called the lead organizations. So they're the primary entity that received the grants from us, and they work with a collection of partners within their community, whether it's county or their alliance, to really improve service care delivery. You can find more information about our hubs and very specifically what they're prioritizing by going to our website, and I'll share that slide later. But as a call to action, I think it's important to really think about, you know, whether you're statewide or you're localized, connecting with these hubs and really looking at the intersection between your work and theirs. So right here is really opportunities to continue to inform our work and to be a part of our work. This is a statewide effort that really has been successful because we have all the partners at the table, because of all of the wonderful work that's already occurring in community. So what you can do is sign up for our SDOH newsletter, where we have updates on the progress of each of the phases. As I mentioned, we've had a number of advisory councils. We love for you all to nominate yourself or others in your organization as we think about future bodies and as we continue to progress this work. Also visit our website, where you can get updates on the different initiatives, especially our SDOH hubs. And then right here, connect with your regional SDOH hubs. We have different profiles for each of the hubs where you can drill down and really see what area they're prioritizing within their communities. And with that, so that we have time for questions, I'm going to stop here and hand it back over for Q&A.
Thank you so much, Nina. I appreciate that. And I did want to just highlight, going back to the beginning of this presentation, when we asked everyone to put in the chat the healthier environments that first come to mind, just hearing not only Nina as well as Dr. Babulal just speak on clean water, fresh air, those outdoor green spaces. Thank you so much for touching on that. So if our panelists would like to please come on camera. And for our attendees, if you have any final questions for our speakers, please be sure to enter them in the Q&A box now, so that way we can go into our panel discussion. So now I'm going to ask Chelsea, are there any questions that we have for our speakers?
Yeah, I'll get started with a couple of questions, and thank you both again for those great presentations. First, I'll start off with a question for Dr. Babulal. In your work, have you worked with health departments or other organizations to implement strategies to reduce dementia risk by promoting healthier environments? If so, kind of what did those look like?
It's a great question, and unfortunately, no. We're really still at the discovery stage right now in terms of trying to delimit the complexities of these relationships and understand how just location and place itself may increase the risk for some versus others. But as many of you may or may not know, research moves at this snail pace, right? Because we're always quantifying and double checking, making sure our models make sense. We're not violating any assumptions. And so, but I do hope at least over the next decade to start working and partnering with local and national departments to ensure that we're not just getting more awareness out there, but thinking about programs that are sustainable and that are equitable, but also feasible across multiple different environments. Because really a solution that might be perfect for one place may not necessarily be implementable for a different geographic region. So we need to think about some more of those universal design.
Great, thank you so much. And for Nina, can you talk a little bit more about the specific collaborations or partnerships that you have throughout Michigan to really advance healthy aging priorities?
So I can tell you, within our department, we have our chronic disease prevention and treatment division, and they've been doing work for years and really have a lot of partners at the table as it relates to that. In regards to our social determinants of health strategy, which is housed within my policy and planning office, we're beginning to really leverage those partnerships that are existing within the department and then think about who else needs to be at the table. So we're thinking about it from the perspective of who's most impacted. So we may have partners that we have those longstanding relationships with and have worked with on previous projects, but who are those maybe grassroots entities that are really being supportive and can connect to the most vulnerable populations? So we really complement each other in that way.
Great, thanks so much. And kind of going off of that, could you talk a little bit more about the role of CHWs at the health department and kind of how they are contributing to all the great work you're doing?
Yeah, so community health workers are amazing. And I will tell you that I just am blown away by the connections that they make and how they are really truly making a difference. And so within our department, we have been able to partner with community health workers in a number of ways. One way that really stands out for me is our Good Housing Equals Good Health program, where we provided funding to local health departments to employ and train community health workers to really navigate those housing resources. There's a number of resources that we've released through MSCI, so the Michigan State Housing Development Authority, where folks were just not aware of them. And so through training these community health workers and pairing them and having them within a local health department, it really helped connect people directly to resources. It really helped us also think about how we can improve our work and make sure that it's more transparent. So it was a learning experience in both spaces, but they've just been so helpful. Community health workers also help in terms of lead abatement. Community health workers have supported food insecurity. Like there's so many different spaces that community health workers can really help address those gaps. But what I love is that they really are about building true relationships. A community health worker may have one person that they call 4 or 5 times a week. They have that relationship of really understanding that person as a person and not just as, a client that they see maybe once a quarter.
Thank you so much. All right, another question that we have in the chat, I believe Ganesh, this is for you. So in reference to some of the studies that you were talking about, one person is asking, racial disparities persist even after controlling for some factors such as income and education. Do you have any thoughts about what factors may be contributing to this gap?
Yeah, I think income and education are very cursory, factors that impact folks at the 40,000 level, but there is a plethora of additional factors, and I saw through a couple of the comments intersectionality, and so there's an adage. Some colleagues from Michigan worked on popularizing it. So for some of us, aging in place is a wonderful thing because you're able to be in an environment that supports and sustains health at every different angle. But for others, you're stuck in place and you might be living in environments that are deleterious to your health that impact it. And so just thinking about, I think some of the components that Nina was discussing, lead within homes, access to clean water. I mean, the Flint water Michigan crisis still continues on to this day. There have been some marked changes within, the working to get more clean access to just these natural resources that we take as universal, freely available components to supporting life. But those are some of the pieces that are the building blocks and the foundation for a person to be able to age in place, but more importantly, to learn, to engage with their environments. But there's a plethora of additional factors. So thinking about structural racism, which, it sounds like it's explanatory, but it's really a multiple intersections in terms of policies like redlining, white flights, disinvestment in certain neighborhoods, access to transportation to be able to go to a job that might offer a lot more pay, for example, than someplace else living in a place that doesn't have access to that. So it's a combination, and I'm happy to put a paper where we've sort of elucidated and built this framework on structural and social determinants of health, specifically using Yuri Brofenbrenner's ecological systems theory that shows, going from the individual level all the way to the macro system, there are these intersecting systems that really are poorly represented by just simply income and education. Last point about education too, when we're thinking about how education is usually measured in a lot of these studies, it's usually the years of education. That's wonderful, but it's again very, very coarse, right? It's, one of the things that we want to look at is that quality of that education, the investment of that city within the school system itself, the teachers and how well they're trained, the composition in terms of the student body to the teacher, what stress looks like. I went to school in New York City when I first came to the United States, and my junior high school, we had bars on the windows, and we had to go through metal detectors day in, day out. That was normal. It was like you're going to, through TSA on a daily basis, right? Moved to Minnesota, where it was the complete opposite. There was freedom. You can come and go as you want. And so the environments themselves, really quantifying and learning to better understand all those components about the built and the natural environment ultimately leads into what we're seeing in terms of the clinic. Why is some people at a higher risk for dementia compared to others?
Thank you so much. I think we have time for maybe one more question, and I think this is a question for maybe both of you. So one person in the chat is asking or stating that they understand that physicians and other healthcare providers are prescribing food, exercise, and other non-pharmacy or non-medical interventions for healthier lifestyles. Do you both agree that that's a realistic approach?
So I don't mind starting. I think that's one approach. There's never, I said this a million times probably, there's never going to be a one size fits all solution. But for some segments of the population, it's helpful. Prescribing food as medicine, prescribing these different resources can be helpful. It's not a silver bullet, so it's not going to fix food insecurity. So we need to be clear in understanding that there's a number of factors that have contributed to food insecurity, and we have to have a more holistic approach as we think about that.
Yeah, and to not also play devil's advocate, but I think that for some it may not be realistic, right? It's like, well, hey, go eat, leafy green and vegetables, right? And you're nowhere close next to a whole paycheck or a whole food, or can potentially afford it, right? Because of the exorbitant costs. But maybe it's just simply not feasible based on the economics of your, not just your job, but also your family. And, maybe we can't afford these healthier foods because we have to worry about paying our bills, paying rent, supporting the children, as getting the books or whatever they might need to go to school. So they're wonderful, and I think they are fantastic recommendations. Deprescribing, shifting this overt focus on pharmacological interventions is this panacea or silver bullet to fix everything. It's not. And apologies to my pharmacist colleagues who are on the call or physicians who are staunch, just ready to write the prescription. But what we're seeing is a seismic shift when we're thinking about precision health and public health. Sorry, precision medicine and public health, where psychiatrists who typically treat mental health disorders by just take this drug are starting to focus more on talk therapy or figuring out maybe we need to look at mindfulness and exercise to ameliorate some of these issues here, because it all ultimately stems from the brain itself, right? The hardware, but also the software that runs on it. So I think to the question, it's a great question. It's not, again, a cure-all for prescribing some of these things. It's got to be within the means of that patient that they're seeing. And the one thing that I typically recommend to my colleagues who are clinicians and that see patients, to medical students, to the residents, and to the fellows when I lecture to them, is ask the patients that you're seeing one question next time you see them. Tell me what's going on where you live. And I promise that question, and I opened this, I presented this 2 years ago when I presented in San Diego for this very similar conference, will provide a bevy of materials and information that they would have never gotten from those, trite questionnaires that they'll typically collect at intake.
Awesome. And thank you, Dr. Babulal, and thank you, Nina, for joining us today and for great, wonderful conversation and presentations. We're still getting chats coming in. So I'll go ahead and share my screen just to close us out. So there we go. So as we're closing out for today's webinar, this is part 4 of 4 in this summer series from the Bold Public Health Center of Excellence on Dementia Risk Reduction. However, this is not our final webinar. So we do ask that you join us November 6th for our Addressing Social Determinants of Health and Dementia Risk Resources for Public Health Agencies webinar, where we'll be highlighting basically the information that we learned from this summer series in that webinar. So that way we can highlight the Social Determinants of Health Toolkit, as well as the other suite of materials that we are offering from the center. And then lastly, I did want to say to stay up to date with what the center is up to and what we're doing, please scan this QR code. We'll be sure to include it in the chat as well, just to stay up to date with what's coming out of the center, as well as we recently just launched our public health curriculum. We've updated our science summaries, as well as, again, we'll be featuring our Social Determinants of Health Toolkit in November. And then lastly, we do ask, as you're exiting this webinar session, there is a 2 to 3 minute survey or feedback form that we would like to just hear your thoughts about today's presentation, as well as the whole summer series. And then lastly, we just want to say thank you to all of our wonderful speakers this summer, as well as we do hope to stay up to date with the work that they are doing, as well as potentially see them in the future on potential other webinars. So I do hope you've enjoyed today's webinar and this summer series, and I hope you have a wonderful rest of your day. So please take care.